topic today will be spanning over 7 topics, subtopics. We're beginning with epidemiology and the global burden, from which we'll now move to pathophysiology and biology of the condition, why Black men are at risk, clinical presentation and diagnosis, screening, debates and guidelines, treatment modalities, and health system barriers and equity. So although I speak quite fast for most, of course, I speak quite fast. So if there's a part of my presentation that is not clear, please call my attention so I could repeat myself or speak more slowly. Okay, so talking about the burden of the disease. Unfortunately for all human beings, the second most common cancer in men still remains prostate cancer. And as at the moment, about 1.5 million people are actually suffering from the disease worldwide. And I am of the opinion from medical school, we're told that when we are told that a disease is 1.4, 1.5, realize the fact that that disease is at least 3 million. Because you have to understand that many people can't even get to the point of diagnosis. Men can't. So it means that when you get 1.47, up to 1 million, 1.1 million of them are in research-rich countries. Unlike we know where we are from. So anytime we talk about Black people, we are very much in transit here. Our real home is somewhere far away from here. So whenever we do 1.47, this value relies a lot on what we get from worldwide, where they have a lot of tests available to them, unlike where we are coming from. But there is higher incidence in Black people. So I realized that back then when I was in Nigeria, I realized that this condition, despite the fact that our people lack funds to make diagnosis for themselves, but you see it's quite common. So it tells you that if this is universal, diagnosis is universal, treatment is universal, we might actually get quite a lot of people with condition compared to what we currently have. Then, despite the fact that we have the incidence, that's the diagnosis up to 2 times in our people. Now, what it means is this. Let's assume that we have 20 people who have cancer, who have this cancer worldwide, for instance. 10 of them are Africans. Now, you find out that 4 times the mortality rate. So up to 4 of that number, despite the fact that we suffer more, we are still going to have a higher mortality compared to other cultures. So like I said earlier from the beginning, I realized that most of my patients who come to this hospital who are Blacks, they come in their 50s, while the white people who come around, they come in their 70s. Despite they being older, frail, having a lot of conditions like hypertension, diabetes, and other comorbidities that would have killed them without the cancer, they come out even better compared to young men from our culture. So we realize that Black people have relatively more mortality. What mortality means is that it means that they die from the condition, unfortunately. But this is actually from a US data that this was gotten from. So Black Caribbean men, by that we mean that we and people who live in the Caribbean face the highest incidence of prostate cancer in this country, actually 264 per 100,000, more than twice what we get in white people. Now, we have to put this in context. The UK population is stratified into 71% of the ethnicity of United Kingdom is white. Now, we're not getting 2 times that disease in people like us. And then the remaining 30% is shared between we Black people, Indians, which are actually large number in this country, Pakistanis, Bangladesh. Despite this country, these people forming a majority, if you combine them with the white people, because if we are to look at it, we could say we Black people in the UK, give or take, are less than 10% of the population. Now we are now having, to put this in context, we Black people in the UK are less than 10% of the population. Now we're not getting 264 of the disease in 10% of people, in 10% of the population, with the people who are almost in the remaining 90% having about half of that. Now, worse for us as Black people, despite having 264, having this number, we still get to actually have more mortality from this number, which is actually not. So it's talking about our genetic predisposition, which is the most important topic to look at. We'll get to that point shortly. Now, the pathophysiology and tumor biology. So right now, worldwide, the value that is used is the Gleason score. So Gleason score. So the Gleason score is what you use, and it relies on 2 basic component through a true cut. I'm going to explain that shortly. Then after biopsying it, then you will take it to it's taken to the histology lab where it will be spread on a slide. And then it will be determined for the kind of tissue system that's involved. Now, this score, the Gleason score 1, 2, 3, 4, 5, that is what there are 5 groups. Now, the Gleason score increases in number. As the number increases, that's how the prognosis gets worse. Now, to begin with, for the Gleason score 1, for the Gleason group 1, the value is usually less than 6. When you combine the value of taking part of the prostate through a true cut biopsy and looking under a microscope, if it is well differentiated, it's actually not a good, no cancer is good to begin with. But whenever we get that it's well differentiated, it means that it's closer to a normal cell than a cancer cell. So in that case, it's actually very low risk. So most of the time in this kind of condition, you want to do continued follow-up, because if you want to treat prostate cancer, it comes with a lot of risk factors, a lot of complications. So you must actually balance the need to treat the patient and the possibility of a complication. It must be balanced. So less than 6 is group 1. Now, for group 2 and 3, is 3 and 4. 3, 4 plus 4, and 4 plus 3. These two things don't mean same thing. So the 3 is focusing on the tumor type, while the 4 is focusing on the histological type. So it's 3 plus 4, it gives 7. So sometimes when you get 7, it's important to ascertain, is it 3 plus 4 or 4 plus 3? So the pathological interpretation of 3 plus 4 is predominantly well differentiated. So the low to intermediate risk. While the other 4 plus 3 is predominantly poorly. Thank you. So, like I said earlier, the Gleason code 2 and 3. They stand for 3 plus 4, which is 7. The second one is 4 plus 3, which is also 7. But this, despite both of them being 7, they do not mean same thing at all. The pathological interpretation of the first one is poorly differentiated, predominantly well differentiated. That's give or take 70% of it well differentiated, while this one is predominantly poorly differentiated. That's about 50 to 70. So that's actually getting towards bad prognosis. The group 3, that's high intermediate risk. With this one, you have to start treatment early and try to reduce the tumor as much as possible and avoid distant metastasis. Then we now have group 4, which is 8. This one is poorly differentiated and is high risk. Then we now have group 5. This one is group 9 to 10. It's undifferentiated, or you can say it's anaplastic, and that's actually the worst you don't want. So when somebody comes with prostate symptoms like lower urinary tract, recurrent lower urinary tract infections, weight loss, back pain, unintentional weight loss, actually, back pain. When the patient presents with all these, the most important thing is to get their Gleason score. With their Gleason score, you can actually give them a proper advice, what to expect. Because once the patient comes with this 9 to 10 in Black people, most of the time, you just want to palliate. You want to tell them, advise them on how to make them comfortable as you want to ease them out. So that is what that's actually stands for. Now, why Black men? Now, etiology and risk factors. By etiology, we are talking about the reason why this happened to us and what predisposed us to this. And broadly, under most conditions, you actually want to categorize them into genetic or biological, socioeconomic factors, healthcare system barriers, and social and cultural. Now, let's begin with genetic and biological. So this genetic and biological, the one thing I find fascinating is that we talk about BRCA1 and BRCA2 genes. BRCA1 and 2 genes are predominant they dominate the management of breast cancers. But surprisingly, they play a major role in men as well to cause them to have prostate cancer as well. Their work, the BRCA1 and 2 gene also influence the ovaries as well, and sometimes the colon. So they can be present in these places. And what we want to understand about, before we go further in terms of genetics, there are some definitions we need to make first. There's what we call proto-oncogenes and anti-oncogenes. What proto-oncogenes are is that naturally, some factors want differentiation of tissues, why some factors are against differentiation of tissues. The one that supports differentiation of tissues are the proto-oncogenes. Why the ones who are against division of cells, these ones are anti-oncogenes. So now the unfortunate reality is that division of cells is natural. Stopping cells from differentiating is also natural. So it's only the what now leads to cancer is when one of these two become uncontrolled. So if you have continuous differentiation that is not properly ordered, that's not properly regulated, you'll be having problems with the proto-oncogene, so the cells keep on dividing. Or the ones whereby anti-oncogene, the cells that are supposed to act as the soldiers against or checkpoints against continuous division, once either of these fail, then cancer comes up. So what BRCA1 and 2 gene do normally, generally, is that they are responsible for repair of DNA. So when there's failure of repair of damaged tissues from maybe too much sun, maybe from food, or something as trivial as just standing under the sun could have damaged the cell. So it's now left some of these genes to stop that cell to create apoptosis, so it dies on its own. Otherwise, they keep on proliferating, which is not what we want. So the genetic factor involve BRCA2 gene, the ATM gene, BRCA1 genes. These are mutations. Once they are mutated, patients have a higher risk of developing this cancer. 8q24. So this case is talking about the position on the chromosome where this problem comes from. So 8q24 chromosomal locus variants more prevalent in the African ancestry, and that's where the problem starts. On that locus, position 24 on the 8th chromosome, that's where the problem starts from. On the short arm of the 8th chromosome, this is where the problem starts from. Then there is lower androgen binding globulin, so leading to higher free testosterone, more aggressive tumor biology at diagnosis. Then family history doubles risk in first degree relatives. So if somebody has their father who had a prostate cancer, then that person should actually be worried about the prostate. If someone's uncle had prostate cancer, then they should actually pay attention to the possibility that they could actually develop it. But then we keep wondering, why do people develop prostate cancer when their father developed it? Because most people who try to remove their prostate early in life so they will not develop prostate cancer develop some nasty complications. Sometimes they have to use diapers all their life because of injuries as a complication. So you can't just say, because I'm 40-year-old, my father had prostate cancer, I'm going to have my own surgery. It might give you lifelong problems, but we'll get to that point at some point in time. Then after the genetic and biological components, we now talk about the socioeconomic factors. So higher rates of maternal deprivation in BME communities. Then unemployment. These ones are more familiar. You can't really prove it. The most important factor here is the genetic factor. But then generally, like they say in medical school, most diseases belongs to the poor. Only few happen to the rich. Among the few ones that happen to the G is gout. That comes from eating so much. But most of that diseases happen to the poor. If somebody is poor, they have a good chance of having sex with everybody, and then they get HIV. If somebody is poor, they have a good chance of having sex with every Tom, Dick, and Harry, they get hepatitis B. Somebody is poor, they have a good chance of getting an accident because they'll be walking on the roadside without a car or something. It eats them, destroys their life. So poverty is on its own compounds problem. But when it comes to prostate cancer, the problem comes more from genetics as against socioeconomic factor. Then healthcare barriers. This one cannot be overemphasized. In the UK, US, relatively, there is some degree of equality here in the UK. But we have heard of multiple cases whereby Black men are poorly given the right medication, poorly diagnosed, there is physician barrier. A lot of things have happened to Black people all over the world, whereby they are biased against letting them use the healthcare system, which allows the disease to fester for a longer time, killing them in the process. That's been something we've seen before. Unfortunately, for where we come from in Africa, most governments have refused to fund hospitals properly. So how do you even make a diagnosis? Now, I am from a country called Nigeria. I'm sure that the PET scan that we have in the country can be up to 2 to serve 240 million people. So if you take Nigeria as a case study, I'm almost certain that that's exactly what's happening almost all over Africa. And even the PET CT scan that is in Nigeria is only in Lagos. And it's not even by government. It's owned by a private company who does it only every Tuesdays, at least last time I was there. So imagine having a PET CT scan for 11 people in a week. That is 44 people in a month to give us, give or take, 2,000 people in a year in a country where you have 264 per 100,000 and we have 240 million. So many people will go undiagnosed. Or the idea of PET CT scan is supposed to map out the area of metastasis to know where to treat. But the issue is that when you tell a person that they have prostate cancer and you can't really tell them if they metastasize or not, and when they start undergoing treatment, you can't even give a proper care to follow up that, okay, the medication we're giving to you is working or it isn't. So these healthcare system barriers span here in the Western world. It can be due to racial prejudice and all that, but in where we come from, it's coming from bad governance, literally. And unfortunately, the Black community in this part of the world is a mere fraction of the rest of the Black people in Africa, where we come from. Black people in Africa is about 1 billion, and most of us in the West, I'm not sure we're out 100 million. That's a slice. So we have to always consider what's happening to our home, where we come from. And then there's psychological and cultural. So many Black men, we know the kind of people that we are. We can be quite ego-driven. Nothing is wrong with me. I am fine. I am strong like a rock. Those factors make us feel like we're untouchable until it gets so worse and there's nothing that can be done. So that's a major factor that affects early diagnosis. So genetics is part of it, followed by socioeconomic. If you don't have money, how do you afford tests? So you can't even get a diagnosis. I remember a time when I was back home, I saw people come for outreach with cryptorchidism. The man could not afford to go for an ultrasound that cost less than £5. So he's coming to an outreach to tell us if we could carry out a surgery on him. We're not even in the hospital when a public street is trying to diagnose people with the disease and point them in the right direction for care. So it's actually that bad sometimes in Africa. And when I use Nigeria as case study, I'm using that because that's basically most of what I know. The other parts of the world, of Africa, which I haven't been to, but I'm almost certain that the situation is not far from each other. Then clinical presentation and diagnostic pathway. So symptom profile and diagnostic pathway. So there's what we call LUTs. That's lower urinary tract symptoms. So this involves nocturia. The person starts urinating a lot at night. Hesitancy, when they get where they want to urinate, might take them up to 3 minutes to wait for urine to come out. Then there's posturing. When you make urine, your urine should be able to hit the toilets and make a little rebound. But you find this one acting like a slow motion. That's posturing. Then there's incomplete emptying. The person finishes urinating and they feel like there's something still left in there. Those are the signs. Then there's hematuria. Seeing blood in urine is actually not a good sign. It requires, in the UK, we use the 2-week referral pathway. Then there is hematospermia. Also, so when the man has sex with his wife, you could see some blood in it. Also, that's also important. It's important to be worried about and take a look at it. Then there is bone pain. This one is it's classically said that when you see a 60-year-old man, whether black or white, comes to you with persistent back pain, you must check their prostates as part of it. So you shouldn't just say, oh, let's give you some analgesic, you can go home. No. Once a man complains of back pain, check his prostate. If that's not there, send him home on other things. But at least you are sure that you've taken out what could kill him in the interim. Then there's erectile dysfunction. A man who has 4 wives, whose reason of marrying 4 wives in the first place was because the first wife couldn't satisfy him, so he needs another wife. Now, all of a sudden, within a year or two, he starts talking about erectile dysfunction. So when a man comes to with erectile dysfunction, one must take it seriously and take a look at it. So that's about that. Then lastly, a good number of patients are asymptomatic, unfortunately. No symptom, nothing, they just start losing weight, and that's worrisome. Then the diagnostic pathway, you use the PSA. This is actually a subjective test. It has been found that as I am now, I'm below 40. My PSA value should be less than 2. So when I'm 40, between 40 and 50, it should be about 3. When I'm between 50 and 60, it should be about 4. Then 60 and 70 and above, it should be around 5. Now, there are factors that affect PSA. If a man has sex with his wife in the last 2 days, it affects him. If he has urinary tract infection in the last 1 week, it does affect him. If he has had a biopsy of his prostate in the last 6 weeks, it increases the value. So when a person comes with a prostate value, one must be very, very careful to just give a diagnosis. We have to understand that there's a lot to interpreting the results, because you have to ask the right questions. Then there's rectal examination. The patient comes in, you stick your hand within their rectum to check for the consistency. Some prostates are actually craggy with some nodules on it. That's worrisome. You have to refer the patient. Then there's what they call multiparametric MRI. This is one of the best diagnostic tools that has made life easy for patients. Back when I was in medical school, when men in their 60s come around for prostate biopsy, it's an intensely painful procedure. You see these men crying from pain. So with the advent of multiparametric MRI here in the UK is the first line of care. Instead of sticking a needle in the patient and make them suffer, with a multiparametric MRI, you can actually analyze the prostate properly instead of subjecting patients to unnecessary biopsy. So you only do biopsy if multiparametric MRI is worrisome. Otherwise, leave the patient alone. Then there is targeted systemic biopsy. So this is the one, there's what they call transperineal approach. So when I was in Nigeria as well, there's an ultrasound procedure, there's an ultrasound probe. It looks like this, like a biro, but quite bigger. So you stick it in the patient's anus. Once you put it in the patient's anus, there's a needle that goes in there with it to take the sample. So it's guided. You are not just going blindly to take anything. No, you are going in there to take that particular tissue that you think is worrisome and you check. So that way you get more accuracy and not tell patient to go home when there's a possible fire on the mountain. Then there's histopathology and genomics. So we'll talk about this one, the Gleason score. Then staging, to stage it, you have to do a bone scan, PSMA, the PET-CT scan for high risk, like we said earlier. So that's how you make a diagnosis of prostate cancer. To move on, PSA testing. So what clinicians need to know. So the prostate cancer antigen is not specific, like we said earlier. Sometimes people have cancer and it shows that they are normal. And times some people are fine, it can show 2,000. So you can't really make it a yardstick, but it gives an idea. So if a man comes to the clinic and they have a PSA value of 1,000, you don't want to tell them to go home. You actually want to tell them to have further tests. So the only idea is just there as the first man to be seen before you send patient for further testings. Then there's prostate density, the PSA prostate volume is 0.15 associated with clinically significant cancer regardless of total PSA. So this is the volume. It's actually important. You could use ultrasound to make a diagnosis, but most of the time you want to rely more on what the MRI gives to you. It's more accurate based on the volume. Then velocity, the rise per year, it matters a lot. So if it's more than 0.75 nanogram, let's say a person gets one nanogram per year, that's a worrisome one. That's the velocity which it enlarges. Then there's a free to total PSA ratio. This is actually important because generally most of these hormones, they are bind to different proteins. So if it's bind to a protein, it's total. If it's not, it's actually free. So if there's a low ratio, less than 25%, it's more suspicious because it shows that there is no control for it. But if it's actually higher, it means there's a lot of control for it. So it shows that it has lesser chance of being a cancer. And then ethnicity adjustment is actually important. You have to always adjust Black men age 46 to 49 due to higher disease. So you see a white man who has a PSA value of 20 and a Black man who has a PSA value of 10. you should more worry about the black man despite having a lesser score because of the virulence of the kind of cancer that we have. So PSA limitation, like I said earlier, the false positive, which has the BAPH, is false positive. Then prostatitis, UTI, vigorous exercise, ejaculation lasts 48 hours. So you have to consider these positives. Then if a person's PSA is actually normal, you have to ask them if they are on any medication like finasteride. It's important to check if they are on anything like that. Then screening debates. So the argument for screening and the argument against. At bottom of all of this, it has more to do with money, because at the end of the day, many people are looking, the NHS itself is looking to manage money. So you have to be careful with sending a lot of patients for tests that they do not need. So the arguments against and for both has to do with money. And then treatment modalities, there are different ways to treat patients. So there's active surveillance, like we said earlier. When a patient has a PSA of Q6M, then you want them to do annual screening of MRI. And this is actually in Nigeria. I don't know about here in the UK, but in Nigeria, many men who are well-to-do naturally just come to the hospital to have MRI. Don't check their prostate. If it's fine, good. If it's not fine, they handle it from there. Then there's radical prostatectomy. This is a long-term process that was in vogue. So you take out the whole prostate, but it comes with a lot of complications actually. So it's lesser in use these days. Then there's external beam radiotherapy, whereby a beam is directed towards the prostate to kill the cancer cells. Then there's androgen deprivation therapy. This one has to do with the androgen. Androgen is what feeds the prostate. So if it deprives it of it, the prostate actually shrink naturally. So that's where the likes of leprolide, Degarex, these are medications that deal with the GnRH. Then there is chemotherapy with docetaxel and prednisolone. Then the other chemical medication that are used. Then PRP inhibitors and targeted treatments. So these are monoclonal antibodies that are used to target the prostate. Then health system barrier and racial equity in cancer. So I think we discussed about this, how implicit bias in clinical practice. Studies show that Black patients receive fewer investigations per symptoms, unfortunately, in this part of the world. But in our Africa, where we come from, Black people receive lesser investigation, not because anybody's biased against them, but just the government has refused to take care of the people. There is a structural racism and the NHS. So data, Black staff overrepresented in lower pay bands, underrepresented in senior posts. So if you're in the lower pay bands, only few Black people are in the top post. Unfortunately, so how do you even advocate for your people if you're not at the top? And recently they've come up with a prioritization system for management, for picking people into residency. So how do you get more Black doctors up there if there's a prioritization of their own people? You can't blame people for actually conserving their own people, but it has just to be done fairly. Then the clinical underrepresentation, less than 5% of UK cancer trial participants are from ethnic minority. Most of these people that come for research are white people. So it means that when the medication are developed, they are developed to target more white people. So Black people have to manage what comes out from it. And unfortunately, where we come from in Africa, our government is not doing anything like that. So we can't even rely on what is being done back home. So community level intervention. So barbershop health outreach, significant uptake increase in Black men. So there are outreaches that have been done these days to help Black people get more screening. And thank God for a group like this, a community-based intervention like this, to teach people about healthcare. There is a clinical recommendation and call to action. So for clinicians, there's a call to actions. For health system, there's a call to action, and community leaders. All these are interwoven. The doctors can't do it alone. The system can't do it without the doctors. And both the health system and clinicians have to consider the community leaders so that more people can be integrated. So for a group again like this, we are very grateful that such opportunity arose to talk to our people about these conditions. So, in summary, 1 in 4 people, Black men, will develop prostate cancer in their entire life. That's actually very bad. That's 1 out of 4. 25% of Black people. So in Nigeria today, for instance, 240 million people. Let's assume that there are 120 million people in Nigeria. 30 million Nigerians are going to develop prostate cancer in their lifetime. That's a huge burden. Africa today is about 1 billion people. That's 250 million Black men who will develop prostate cancer in their lifetime. That's not a good statistics. That's a lot. Then 40, when the person is 40, they have to start taking themselves serious, starting multi-parametric MRI. I go to Nigeria once in a year. So I walk to a lab, ask them to do multi-parametric MRI for me to check me out. I do it I'm not 40 yet, but that's the plan. I will be doing it, God willing, and hopefully nothing will be found. Then 40% reduction in mortality if cancer caught early in stage 1 and 2. So despite the fact that we Africans have a virulent prostate cancer, despite this, if caught at stage 1 and 2, we have a good chance of surviving. And then less than 5% of BMA participant rate in UK research clinical trials. That's actually very bad. Less than 5%. Then this is the point where you can ask the questions that you'd like to, if you have any. Thank you.
Thank you so much, Dr. Oro. Very thorough. But before we go into any discussion, would just like to highlight a few of the things that was mentioned. We know that prostate cancer remains one of the most common cancer affecting men, but the impact is not experienced equally across all communities. And as Doctor said, Black men face a significantly higher lifetime risk, with around 1 in 4 expected to develop prostate cancer during their lifetime. So, is there any questions? Is there any comments? And we're open for that. If you want to raise your hands or you want to drop something in the chat box, I'm quite sure you might have heard someone who have experienced prostate cancer. If there's any questions you want to ask, go ahead and do so. Thank you.
I heard you say that PSA result is subjective. Could you say more about that? But does that mean that apart from PSA or after PSA test, there are still further tests that are required to be sure that one has or one doesn't have?
Okay. Thank you very much for that question. So the PSA test is called prostate specific antigen. It's subjective because it depends on what the person had done prior. So for instance now, there are false positive, there are false negative, there are true positive, and there are true negative. What that means is this: a patient comes in with the patient is 68-year-old, so he's having lower urinary tract infection, he's having blood in his urine and all that. Now you now tell him to carry out a prostate test. But this man had sex with his wife yesterday. Automatically his prostate goes up, his PSA goes up. If this man had seen a doctor or something, or let's say this man is a gay man, for instance, so he had some sexual intercourse with a man in the anal orifice. If he does the PSA test after that period, he's going to have elevated PSA, because even if you put hand in a person's anus, the PSA goes up. That's one. Now, sometimes a patient has not done any of this. This man has been in let's say in a monastery. He has not had anything to do with anybody. He has been on his own. This man can still get a value of 1,000 in the absence of, because that's too high. Let's say a value of 20. And it will turn out that this man's prostate is actually fine. And there are people who are young, they have a value of 3, they have prostate cancers. The unfortunate reality is that I have seen all of this before. So to diagnose, to get a better diagnosis of prostate cancer, it's better to to have a multi-parametric MRI. Now, one of the reasons why I personally like to use this particular multi-parametric MRI is because in the UK, it's almost impossible to carry out a multi-parametric MRI for no just reason. You start explaining. And even at that, the doctor might just tell you that, doctor, go and use trimethoprim. What you have is UTI. NHS does this a lot. So, but one advantage I usually tell our people is that you are from Nigeria, you are from Ghana. Our system is a money-based system. So you can MRI in Nigeria is about 150,000 naira. Now, I don't think it's up to that, but that's even the highest it could be. Now, if you want to carry out multi-parametric MRI in Lagos, for instance, that's about 75 pounds or even lesser. I am of the opinion that instead of carrying out PSA on its own, if someone has the money and it does not radiate there's no risk of causing cancer or something like that in the future, since it's magnetic, I advise African men, when they go to their country, they should carry out what they call comprehensive body check. They do it quite a lot in Nigeria. Where you go into the place, nothing is wrong with you. You just have all these tests, MRI of the prostate, and they check it for you. So PSA is at the rudimentary level. It's not even when you get a result that is normal, let's say 2 in a 60-year-old man, it can be negative. It might be a person has a cancer, it just did not pick it. So you can't actually use it as a yardstick to make a diagnosis. Hope I was able to answer your question.
Yes, thanks.
Tanya, are you still there?
I'm still here. Can you hear me?
Okay, we can hear you now. Go ahead.
Okay. Sorry, the thing keeps logging me off, keeps kicking me out. So it wasn't really a question as such. It's just that because I was aware then that the doc was talking about the different countries and their kind of pathways, their investigation pathways. So I just wanted to just add in a few things, if that was okay, just to kind of just fill out some meat on the bone, if that was all right.
Tanya, can you just say who you are?
Oh, yeah, sorry.
Who they are. I know who you are, but others don't.
Sorry, my name's Tanya. I'm a urology oncology clinical nurse specialist. So I work specifically with patients that have prostate cancer and other urological cancers as well. So over here, yes, that pathway is correct. It's PSA. If there's a raise, I just wanted to say as well, because I know the doc put out some figures out there, but I just wanted to kind of just clarify with that. PSA is age specific. So according to the man's age, that there is a safe upper limit that they would have. So, and it's quite low in terms of the numbers that we were hearing. So for a 60-year-old man, we would expect his PSA to be less than 4.5. So even if the man went to the doctor and the PSA came back at, say, 5, he would qualify for the 2-week wait pathway in the absence of any other symptoms that could cause that. And I just wanted to touch, because we were just talking about, well, the doc was just talking about the other aspects of it. For the people that aren't aware or don't know, the prostate, it's an organ of the urinary and reproductive system, and it sits at the base of the bladder. So it wraps around the urine pipe. And in the urine pipe that's covered by the prostate, there's a little hole called the vermontanum, and that is where urine could possibly pass through that pipe and into the prostate. So if there's a urine infection and that gets into the prostate, it can cause inflammation, and that can raise the PSA, and I'll tell you why in a sec. And also, when the doc was talking about hematospermia, so blood in the sperm, the prostate produces about 30% of the fluid that you see in the ejaculate. Okay, so that's how it works within the reproductive system. So when it squeezes, it produces that fluid, and that then enters the vermontanum and through the water pipe, that we see. That's where men ejaculate from. So again, the PSA is an enzyme. It's something that is on every single prostate cell, and there's only more of it that goes into the blood if there is activity in the prostate. So when these cells start moving, if they break, or if there's any infection or anything like that, more PSA from the prostate leaks into the blood, and that's why we use that as an indicator. It's prostate activity specific, it's not cancer specific. And that's why the doc was saying you can't just use PSA on its own to say that a man has prostate cancer, because there could be other issues. He could have just ejaculated within the last few days, he could have had a urine infection, and also the prostate naturally gets larger as you age. And that can come with problems, like the doc was saying, you know, the slow flow and the hesitancy, because the prostate gets bigger and squeezes around the urine pipe, so it stops things from working properly. So that can come with those problems, those LUTs that the doc was talking about, or it can come with no problems. It can just get bigger and everything's still fine. But the more cells there are, the more PSA there is, because PSA is on every cell. So if your prostate's getting bigger without the presence of cancer, PSA can still go up. So there's a few different reasons why the PSA goes up, and that's why it's not just used by itself. The MRI is used in conjunction with that, because as the doc said, it gives an image of the prostate. So then when you know what something is supposed to look like and it looks abnormal, then you can use all of that information together to guide you whether you need to take a biopsy, take some tissue from this organ or not. But one of the things with the MRI is that it can miss up to, you know, it's a significant amount. It can miss up to 25% of prostate cancers.
Yeah.
So again, you know, it's a score system as well, 1 to 5, 1 and 2, not so much a problem. 3, okay, we'll look at everything else. Is there a family history? 4 and 5 will definitely go to biopsy. And the biopsy issue now, that is the main thing that puts men off, apart from the DRE, the digital rectal examination, the finger in the back passage. The biopsy, it is painful. The one that the doc described is an older style one now, which is transrectal, as he described, and the needle passes through the rectal wall. So there's a higher chance of infection because you know you're passing fecal matter into the prostate. So that came with a higher chance of infection. And again, that piercing through the back wall is painful. So the one that is the kind of gold standard here in the UK now is called a transperineal route, which is basically the perineum, the area between the testes and the anus. So the needle goes directly into the prostate, takes a snap of this tissue and pulls it directly out. So the risk of infection is much, much lower. And I assist with these biopsies every week, right? And yeah, it is painful, but on the whole, it is much more tolerable than the old style ones. And I've said for a long time, if we could get somebody to agree to actually have, you know, particularly covered up and everything, but actually produce a video of a prostate biopsy, so that men, because I think when you don't know, that is the scary part, you know, you drum up all of these fears and you listen to Bob down the pub and all the rest of it, you know, and you just back away from doing these things. So I do think if we could get somebody that would agree to do that, it would be very helpful as an educational video to show men, well, this is what it's going to be. Yes, it's going to hurt because we're going to give you some needles to numb it. The painkiller is the thing that causes the pain, ironically, but you'll get through this. And that's what, and it only takes a few minutes as well. You know, so it is difficult, and you know, and like I say, you know, the position that these men are put in, they're laying on their back with their legs up in stirrups. You know, the probe is in the back passage so that the prostate can be viewed. The needles are going in. Just psychologically, that position is very vulnerable. And, you know, I see a lot of men, I hear some colorful language, and, you know, I see because they're asked to hold the scrotum and the penis up and out of the way while everything is happening. And some of them, I think that they're going to pull it off and they're going to leave with it in their hand. You know, it's very, very difficult for them. So we do need to find a way to educate them and tell them the truth, but also let them know, listen, you can get through this, you know, and we're here with you to help. So that could be something. Also, the PSA level, we know that Black men have a higher rate of when they present with prostate cancer, they tend to be at a higher grade and at a younger age. So really what we need to be doing more proactively is making that PSA level, that safe upper limit, lower for Black men, because we know that it's not as accurate as it is for the white and Asian counterparts. Now, that doesn't mean that it's wholly inaccurate. It can still be safely used, but it's something that needs to be looked at, really, you know. One thing that I didn't hear the doc mention that I just wanted to put in there as well, because when I speak to my patients, especially my Black patients, and funnily enough, you know, many white and Asian men say it to me, you know, I hear that Black men are at higher risk. Like, what's that all about? And honestly, when I explain it to them like that, it's they are understanding, you know, and you can just see it clicks in them, you know. So one of the things that I didn't hear the doctor mention was the testosterone level. Black men produce a slightly higher amount of testosterone than their white and Asian counterparts. And testosterone, much like in women, our estrogen governs our monthly cycles, our breast tissue, that kind of thing. Testosterone does the same thing for the prostate and muscle mass and that kind of thing. So in Black men, there's much more testosterone and many more. And testosterone is known as an androgen, and the androgen receptors are located inside the cell, inside the prostate cell, and Black men have many more androgen receptors. And that complex together, those two together, like the lock and key, they start to they have a hand in how the cell replicates itself, its life, its ability to kill itself if anything goes wrong. So you can imagine if you've got more testosterone telling the cell to replicate faster, it increases. If the man is going to get prostate cancer naturally because of genetics or exposure, DNA damage, that kind of thing, because of that testosterone and androgen complex, he's likely to present with a higher grade, a more aggressive type of cancer. And that's the thing with the black men. So I just wanted to put that in as well. The screening thing, it's screening is it's controversial, you know, because it's one of those things, you know, cancer, as the doc said in the beginning, it crosses every board. You know, I heard somebody with an eye cancer the other day, and I'm like, I haven't heard that in many a year. I don't think from when I was at uni.
Yeah.
So, you know, it crosses across everything. But on the whole, and it's not a popular statement, but prostate cancer will not kill you as quickly as lung cancer, as bowel cancer, as pancreatic cancer, as breast cancer. And so they will likely put the funding into screening for those cancers because of the higher mortality level. You know, and prostate cancer, as we know, it's typically a disease of aging. You know, most men over the age of 80 will have some form of prostate cancer. You know, if they died of something else and you biopsied them, most of them would have some form of low-level indolent prostate cancer. But like Doc said about the active surveillance, if you had a diagnosis in your Gleason score that we spoke about was a low Gleason score, so that the cells were still kind of in control of themselves, the cancer hadn't taken over the cells and it wasn't going to be very aggressive, you would likely die of something else rather than that prostate cancer.
True.
So it's one of those things. It is a money thing, absolutely, as the doc says, you know, but there has to be a level of practicality as well, I suppose, you know. The cultural competence that we spoke about, you know, as you say, there's such a low level of black higher level staff, and even just representing I'm the only black person in the whole urological team on the nursing staff, you know, including the ACPs. There are 2 black consultants out of 9. The majority of them are Asian, and there are 2 white, 1 white British, 1 white Italian. And as we say, black men, 1 in 4, and I'm the only person on the team. Like, how is that representing what the actual stats are saying, you know? And those that are, I've heard some things, you know, since I've been a urology CNS, you know, oh, black men, you know, you'll see when they come to the clinic, they're all stupid, they don't want the treatment, as long as they've got his woman, you know, all these kind of things. You hear this rhetoric from white middle-aged women, and you have to say to yourself, well, is it any wonder that black men don't have any trust in what we're doing and what, you know, and what we say? So the other thing was, as the doc said, about lack of research, you know, in from black people. And I think, again, it goes hand in hand with this lack of trust in the systems, full stop. You know, they're not gonna have me as a guinea pig. No, I don't know what they're putting in there, and da-da-da-da-da. You know what I mean? So I think one of the things, I don't know if it's possible because research is not my field, so I don't know the makeup of it, but if it would be possible for some kind of research to be kind of visibly fronted by black people, for black people, you know, analyzed by black people, and that kind of thing, if that was visible, maybe it could go some way to improving our drug choice and that kind of thing, you know, and even our diagnoses. So and also I was, you know, I've been saying for a long time, my peers are absolutely sick of it, but I really do think there should be, this is one of the reasons, even forget the 1 in 4, the 1 in 8 alone, you know, there should be a urology community CNS, you know, there should be a surgery, a space within the surgery that a urology CNS can go once a week to different surgeries and offer PSA testing, you know, counsel men about it, do the risk assessments, that kind of thing, because it's rife, you know, and as you say, early bird catches the worm, you know, so that was something. And then
I'll link you up with Kevin from Prostate UK. I'll get in touch with you.
Lovely.
And
yes,
that connection, because
that'll be brilliant.
Do some work with Kevin and Michael from the Royal College of Nursing as well.
That's amazing.
He normally
Thank
comes
you.
on when we do this. Thank you so much, Doctor. I
Thank
want to
you.
ask you some questions. Thank you so much, Tanya, because
Thank you. Thanks for letting me go on. I'm sorry I went on a rant there, but yes.
No, it's fine. And I'm quite
email
sure
address.
we work together as a team with this community project that we do. It's all about working together as a team, and we're so happy to have you on tonight, Tanya,
Oh, thank
because
you. I'm absolutely pleased to be here.
compliment Dr. Aro. Thank you so much. Dr.
Well,
Aro,
thank you.
I've got a few questions for you. Give me a second, Tony. Just give me a second.
Okay.
There's a few questions. How can I prevent this with my lifestyle? Like what to eat and recommend exercise? And that's from Olo Ascope. I hope I've pronounced that name right.
Ascope.
Yeah. Thank you, Doctor. Over to you.
Okay. Thank you, Mr. Olakope, for that question. So at the core of prostate itself is genetics. What fits into prostate cancer is the testosterone level. So I've seen a lot of people say much about eating this, not eating that. In my view, it's still anecdotal at best, because something that's genetics that is part of you, how do you not do much about? And if you try to do, if you look at it from the possible feed of the cancer itself, it's testosterone. So I'm not so sure food does a lot to help, really. I've not seen a lot of research work in that direction saying that if you eat this or you don't eat that, because it's not exactly a heart disease or some kind of disease or hypertension that you can say exercising and stuff like that. At best is to do surveillance checks. It's not like you have any problem, you just have checks with your GP from time to time. So that's a better way to go about it than when you try to look at it from the point of food, exercise. Yes, it's good to do exercise, of course. It keeps the body healthy. But ultimately, it's about testosterone and genetics.
Thank you so much. Next question is, some prostate becomes chronic. Is it difficult urinating? Does it leads to cancer? And that's from Chris O.
Oh, okay. That's a beautiful question. Our friend has asked here. So the thing is, overwhelming number of prostate problems is not even cancer. It's what we call benign prostatic hyperplasia, where the prostate becomes enlarged not evenly, unevenly. That's the word. So because the kidneys are up here, can see me. So the ureter passes down into the bladder. From the bladder, the ureter now passes through. So now at the base of the bladder is the prostate. So let's say this is the prostate now. So through it like this, in the middle like this, is where the ureter passes through it. So now as it
What
passes
if I?
through it, the prostate can get unevenly enlarged, and then it grips it like this. So that's what you're describing. What you're trying to describe is what they call benign prostatic hyperplasia. So it's actually a benign condition. It doesn't have. Can a person who have benign prostatic hyperplasia have cancer? Yes, theoretically and even realistically, it's possible, but there are two different conditions. Overwhelming men, because we said earlier that about 1 in 4 men who have prostate, who will develop prostate cancer in their life. This is more common among Black people. But the remaining 70% will eventually still have something related to prostate, but it's just maybe BPH, prostatitis, and other conditions relating to the prostate. So that's what you're describing is a benign condition. It can be chronic and it could be acute urinary retention, but it's not related to prostate.
Dosamo. I have a parent of one of my pupils that has prostate cancer, and he had to go back home because the hospital bills are increasing and he can't afford to do the operation yet. Can he be helped in any way? That's
Okay.
that question. Where is the person? We don't know where that person is. And we are speaking from the UK. The next question is there any preventative medication for it? Or what are the likely preventative? What are the likely preventative? Don'ts?
Okay. So thank you for that question. The prostate, like we said earlier, the prostate cancer, benign prostate hyperplasia. Unfortunately, is a very funny disease because at the core of what makes you a man is your testosterone. Now, this testosterone that's supposed to make you a man, have now decided to feed your enemy. So if you go hard against it, trying to reduce your testosterone, you lose your man virility. So it's actually a very dicey condition. So that's why when you want to treat, sometimes you take out the man's scrotum. But it's nice if an 80-year-old man loses his scrotum. It's a nice problem. No problem. The man doesn't even have a need for it in the first place. But imagine a 40-year-old man losing his prostate, losing his scrotum. That's a lot of disaster. at least for African men who pride a lot on those kind of features. So you cannot, the most important measure that could be done is that once you are 40, you can actually decide that you must be intentional about your health, taking care of your blood pressure, your sugar, having recurrent PSA. Like my sister said earlier, that the value from 40, the expected PSA value is about 2. So between 50 and 60 is about 3. Between 60 and 70 is about 4. And then at the cap of 70 and above is 5. Now, if you are 40, it makes sense that at least twice a year you go for a PSA test. So even if a cancer is to be developed, to be seen, let's assume that in January you had a PSA test, a 41-year-old man, and you are getting a value of, let's say, 1.2. That's a good result. So by maybe June or July or thereabouts, you go for another one again. It's just a blood test. So you can make a 2 times a year test. So if anything is even seen, you see it in stage 1. So you go after it on time and you move on with your life. So it's more of a preventive problem, because it's not like blood pressure. You can say, okay, avoid too much salt. In this case, you cannot avoid your testosterone. It's what makes you who you are. So what you can do more is preventive.
Brilliant. Any more questions? We've got time for one more question. I apologize, we have run over tonight, but this topic is really dear to a lot of us. And is there any more question? Tony, you wanted to come in?
Yes, I actually wanted to ask Tanya that I need her email address, because I might be referring one or two people to her. Yeah, at this stage, because I mean we're actually gone out of time now. I want to say heap thanks to the men. We should try as much as possible to do early tests. I think that's the main takeaway. And I'm appealing to every one of us, everything that we have learned tonight, don't let us just be hearers alone. Let's put them in practice. You know, that's the purpose of this platform. And I'm hoping that we can also collaborate. Like Tanya came on board tonight and she said a lot of things. If there are any of us that have suggestions on, like for instance, she said something about eye cancer tonight. This is the first time I'm going to hear it. Some time ago, we heard of breast cancer in men, and we brought people to speak about it. So if you have suggestions, please let us know. So all I want to say now is thank you very much indeed. Thanks to everybody that has joined tonight. Our webinars are always on the YouTube. The only thing is that we don't send it to YouTube immediately. YouTube will not take more than like 55 minutes, so we try to edit it. That's why it's delayed. But if you go to our YouTube channel, Come Let Us Community Project, you'll find all our programs there. Thanks very much.
Thank you very much.
Thank you. Thank you so much.